Whereas aortic stenosis, the valve is not opening properly. Aortic insufficiency, the valve is not closing properly. Um, so, you have to understand the terminology there. So, because the valve is not closing properly, there's going to be backflow across the valve. So remember the valve, the aortic valve allows blood to get out of the left ventricle and into the aorta. When you have aortic insufficiency, when the aortic valve closed, there's a little bit of blood going, there's blood going backwards across the aortic valve into the left ventricle. So aortic insufficiency is a diastolic phenomenon. Okay, so because the aortic valve opens in systole and closes in diastole. So in diastole, when the valve is supposed to close, blood can still flow backwards across the valve into the left ventricle. So what are some of the causes? What cause aortic insufficiency? Endocarditis, so anything that prevents the valve from closing properly. If you have endocarditis and vegetation on the aortic valve, it's going to prevent proper closure of the aortic valve, so the patient will have aortic insufficiency. There was some medication, weight loss medication a few years ago that got a lot of press because they caused valvulopathy, valvular problems. And one of them was you must have heard about fenfluramine. These are weight loss medications that cause valvular problems. Marfan syndrome, where the ascending aorta is dilated. So if they just think about it, if the ascending aorta is dilated, then the valve does not close properly because the valves are pulled apart. And so you're going to have backflow across the aortic valve in diastole. Ehlers-Danlos, for the same reason. Ehlers-Danlos are these individuals who say they're double jointed. They can twist in all sort of shape. They also will have, they can develop aortic aneurysm and aortic insufficiency. Ankylosing spondylitis can do it. Lupus, systemic lupus erythematosus can also give rise to aortic insufficiency, but the big ones are anything that dilate the aortic root. Anything that dilate the aortic root, endocarditis, rheumatic fever can do it as well. Okay, so a very important assessment is the evaluation of the severity of the aortic insufficiency. You have to know how to determine whether this is mild, moderate, or severe. And there are multiple methods. You should know all of the methods, okay? And you have to combine them. So no single method should be used. So it should be a combination of the methods. So we can use what we call the proximal jet width. This is aortic insufficiency. So again, aortic insufficiency is a diastolic problem. You see the aortic valve is closed in diastole, but it's still leaking. So this mosaic or blue color, this is the aortic insufficiency. Your transducer is right there. So the blood is flowing from the ascending aorta across the aortic valve and into the the left ventricular flow track and into the left ventricle. It's moving away from the transducer. That's why it's more blue. Okay. You're going to have some amount of turbulence. So it usually looks mosaic, a mixture of the colors. So you measure the width of the jet and compare it to the width of the left ventricular flow track. So that's how you assess that. And then so with this method, you assess the width, you measure the width of the jet, and you compare it to the width of the left ventricular flow track. If the width of the jet compared to the left ventricular flow track is greater than or equal to 65%, then we call it severe. We say the aortic insufficiency is severe. If the width of the jet compared to the width of the left ventricular flow track is less than 25%, it's mild. So this is a quick method and you should use it. Okay? So you measure the width of the jet and you compare it to the width of the left ventricular flow track. Severe if it's greater than or equal to 65%, and mild if it's less than 25%. Anything in between is moderate. So you measure the width of the jet, the regurgitant jet, compare it, and you're going to measure the width of the left ventricular flow track. Another method that we use is the pressure half-time method. Okay, so again, remember everything in echo is gated. Your ECG is on top, and you put your cursor across the left ventricular flow track, and you measure the pressure half time. That is the time it takes for the pressure to fall to 1/2. Okay, so all you have to do is put your cursor at the peak and at the lower portion, and the machine will give you the pressure half time. So using this method, severe aortic insufficiency, if the pressure half time is less than 200 milliseconds, and it's mild aortic insufficiency if the pressure half time is greater than 500 milliseconds. Anything that falls in between is moderate. Okay, again, you put the cursor at the peak of the AI envelope and at the lower velocity. Okay, the machine will give you the pressure half time. If you have a machine that gives you deceleration time, you need to know the relationship between pressure half time. You need to know the relationship between pressure half time and deceleration time. Pressure half time is equal to 0.29 times deceleration time. Okay, and you have to know this relationship because some machine will only give you the deceleration time, and you have to know how to convert it to pressure half time. Okay, so this is the pressure half time, and you have to use C Doppler, continuous wave Doppler, in the apical 5-chamber view. Okay, what pressure half time means is the time it takes for the pressure to fall to 1/2. So at this at this level right here, the pressure is a certain value, and remember we showed you how to convert velocity into gradient using the modified Bernoulli equation. Pressure is equal to 4v². So you know the pressure there, and then you want to find the time it takes for the pressure to fall to 1/2. Okay, but the machine gives it to you. So you just from the peak to the lowest velocity. Okay, if you were to go to the base, then that would be the deceleration time. And the relationship between pressure half time and deceleration time, the pressure half time is equal to 0.29 times dt. Okay, so if the pressure half time is less than 200 milliseconds, the AI or aortic insufficiency is severe. If the pressure half time is greater than 500 milliseconds, then the pressure half time, then the AI is mild. Another thing that we look at is the density of the jet, the density of the AI jet. If it's very, very dense, bone dense, then it is severe. If it's faint, like this one, this is very faint, then the AI is mild. Okay. All right. So just going over everything. Okay. Um, so in the parasternal long axis view, you measure the width of the AI jet to the width of the left ventricular flow tract. If it's greater than or equal to 65%, it is severe. If it's less than 25%, it's mild. You do your C doubler in the 5-chamber view, C double in the 5-chamber view. If you have a faint jet, if the jet is faint, it's more than likely mild. If the pressure half time is greater than 500 milliseconds, it's mild. Okay, and so you look at the density and the pressure half time. Another important thing that you will get in your exam is when you do your look at your descending aorta. So you remember you do your suprasternal notch view, and you put your cursor in the descending aorta, and you press your P doubler button. If you get this, you get a nice envelope in systole and you don't get any significant diastolic flow reversal, then again your AI or AR is mild. With severe aortic insufficiency or aortic regurgitation, you measure the jet, the width of the jet to the width of the left ventricular flow tract. If that's greater than or equal to 65%, it is severe. You do C doubler across the aortic valve in the 5-chamber view. If it's bony dense like this, it's more likely to be severe. And if the pressure half time is less than 200 milliseconds, then more than likely it is severe. Okay, so with the continuous wave Doppler, you look at the density and the pressure half time. Again, if the machine gives you a deceleration time, then the pressure half time is 0.29 times the deceleration time. And then with your descending aorta, suprasternal notch view, and you put your cursor in descending aorta, if you get this Euler diastolic flow reversal, so it's all of diastole, you get this flow reversal, then the AI is severe. And those people who are doing the exam, this is going to come. I'm going to tell you this. I give you one question. This is going to come. All right. They're going to give you an AI, and they're going to give you all sort of stuff, and then they're going to give you the descending aorta. They're going to give you the descending aorta. They're going to show you Euler diastolic flow reversal, and they're going to ask you, is this mild, moderate, or severe? Once you have Euler diastolic flow reversal, okay, You can see the diastolic flow is on top. ECG is on the bottom. Systole is from the onset of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. So the flow, the diastolic flow is reverse. Okay. All right. And that is because the blood is going backwards. All right. So that makes it severe. All right. We can also use the PISA method, the famous PISA method, to evaluate aortic insufficiency. Again, PISA stands for the proximal isovelocity surface area. We went over that in detail when we did hemodynamics. So when we look at AI, if the vena contracta is this supposed to be greater than, yeah, right, so this is great. So if the vena contracta is greater than 6 centimeters, 0.6 centimeters, or 6 millimeters, the AI is severe. If the vena contracta is less than 3 centimeters or 3 millimeters, then it is mild. And remember, when we did PISA, one of the things we did when we look at PISA is to calculate the effective regurgitant orifice area, because when you have regurgitation, that regurgitation is going to occur across a dynamic area, depending on the severity of the AI. If the AI is more severe, then that area is going to be larger. If the AI is mild, then the area is going to be smaller. So if you just think about it. So when we use the PISA method to calculate the EROA, if the EROA is greater than or equal to 0.3 centimeters squared, because the area we're talking about, then it is severe. If it's less than 1.1 centimeters squared, then it's mild. You can also calculate the regurgitant volume, because there's a certain amount of volume that's going back. If the regurgitant volume is greater than or equal to 60 mLs, then it's severe. If it's less than 30 mLs, then it's mild. And then if you talk about regurgitant fraction, it is severe if the regurgitant fraction is greater than 50%. That means more than half of the blood is going backwards. That sounds severe to me. So it is severe. If the regurgitant fraction is less than 30%, then it's mild. So remember, when you have regurgitation, so let me just draw this because I can see the expression in some of you guys' face. All right, so say we have regurgitation occurring across, so if this is the aortic valve, okay, and this is the regurgitation. If this is the regurgitation right down here, and this is the PISA that is set up on top. So we're looking at so this is the aortic valve. So this is the regurgitation down the bottom. Excuse my drawing. Okay. So if this is the regurgitation down below, and then, so when you have regurgitation occurring, remember what we said from hydraulic principles, you're going to have a series of concentric shells above the regurgitation, and all along the surface, the velocity is going to be the same, and that's why it's called isovelocity surface area. And there's a radius to this shell. Okay, so this is the shell on top. This is the aortic valve right here. I'm gonna separate out the shell and show you something. So if we separate out the shell, I mean, oh my goodness, this drawing is just horrible. All right, I'm gonna erase this and come because this drawing is just atrocious. All right, so let me see if I can use this. All right, so if we use this as the shell right here, so if this is the shell. All right, so all right, and I'm going to draw over here. So this is the aortic valve. Oh, this thing just have a mind of its own. All right, let's go again. All right. So all right, I'll tell you what. Let me draw the aortic valve. All right, the aortic valve. So this is AV for aortic valve. Okay. So when you have regurgitation, so below you're going to have the big regurgitation down the bottom. So this is the regurgitation occurring across the valve. Above, you're going to have your pizza. So just view this as a nice hemispheric shell on top, right? So let me just separate out the hemispheric shell. So, so if you were to separate out the hemispheric shell, it actually is like this. So this is the hemispheric shell. And the valve plane would be right here. Okay. So you already know everything about the hemispheric shell. You know, the radius is from the valve leaflet to the top. That's the radius. Along the hemispheric shell, the velocity is the same. That's why we call it isovelocity. Iso means same. So the same velocity along the shell. But what I want to tell you about is the EROA. The EROA is where the regurgitation occurring, the effective regurgitant orifice area. That backflow is occurring across a dynamic area. That area can vary depending on the severity of the regurgitation. If the regurgitation is large, the area is going to be larger. If the regurgitation is small, then the area is going to be smaller. And this is the area through which you have the regurgitation. So, you know, from there to there, that's the area. Okay? Remember, if you could cut across it, that area would be circular. You know, the area would be circular. So you can measure the area. You can also measure the width through which the regurgitation is occurring. And the width through which the regurgitation is occurring is that's what we call the vena contracta. You can see it's a number, it's a distance. So the width through which the regurgitation is occurring is called the vena contracta. Okay? And that is what you can measure. Okay? The area through which the regurgitation is occurring is called the EROA. effective regurgitant orifice area. Whereas the width, that's what we call the vena contracta. And you're going to see these terms repeatedly. So what we're saying is that if the patient has severe aortic insufficiency, and you measure the width of this, it's going to be greater than 6 millimeters or 0.6 centimeters. If the patient has mild aortic insufficiency, then it's going to be 3 millimeters. It's the width, not the area. Okay, it's going to be less than 3 millimeters or 0.3 centimeters. But if you calculate the area, and remember we went over how to calculate the EROA in our hemodynamic session, because with the conservation of mass principle, the regurgitant flow is equal to the flow at pizza. The regurgitant flow, again, flow is equal to cross-sectional area times velocity. So the regurgitant flow would be the AI velocity times the EROA, right? That's the area through which the regurgitation is occurring. And then that's going to equal to the flow at pizza. Again, flow is equal to cross-sectional area. The cross-sectional area of an hemisphere is 2 pi r squared. And then you use the Alyson velocity as the velocity, because that's the velocity you're going to adjust to get a nice shell. Okay? Again, vena contracta is the width of the regurgitant jet, okay? And the EROA is the area, the effective regurgitant orifice area. Regurgitant volume, it just means that the volume of blood that's going back. And this is each beat. This is each cycle, each beat. So if the regurgitant volume is greater than or equal to 60 mLs, it is severe. If it's less than or equal to 30 mLs, then it's mild. With regurgitant fraction, if more than 50%, more, if the regurgitant fraction is greater than or equal to 50%, then the AI is severe. And if the regurgitant fraction is less than 30%, then it's mild. You have to remember this because you're going to get it in an exam and they expect you to remember it. All right. So that's all right. Okay. So we said all that we said before to get to this table. Okay, you have to memorize this table. You have to know the table. This is the table that will help you to determine if the aortic insufficiency is mild, moderate, or severe. So let's start with severe aortic insufficiency. Severe. So the aortic insufficiency is severe if the central jet width is greater than or equal to 65% of the LVOT. So we showed you how to do that. You get the width of the jet and you compare it to the width of the left ventricular flow tract. If it's greater than or equal to 65%, then the AI is severe. The vena contracta, that is the width of the regurgitant where the regurgitation is occurring, the width. If it's more than 6 millimeters or 0.6 centimeters, then it's severe. And then the pressure half time, we showed you using C doubler, if the pressure half time is less than 200 milliseconds, it's severe. The diastolic aortic flow reversal in the descending aorta, suprasternal notch view, P doubler. And if you have diastolic flow reversal, it's more than likely severe. And because you're getting a lot of blood going back into the LV, the left ventricle will be enlarged. So those are some of the things. And then when you look at the density of the C doubler, it's going to look very dense because the density tells you how much blood is flowing backwards. And then regurgitant volume, if the volume that's going backward is more than or equal to 60 mLs, it's severe. If the regurgitant fraction, the amount, if compared to what's going forward, if the regurgitant fraction is greater or equal to 50%, then it is severe. And then the EROA, effective regurgitant orifice area, we show you how to calculate that using the fact that the regurgitant flow is equal to the flow at pizza. If that EROA is greater than 0.3 centimeters, 0.3 centimeters squared, 0.3 centimeters squared, then it is severe. Then all you have to do is know what's mild, and then anything that falls in between is moderate. So for mild AI, the central jet, so you measure the jet to the width of the LVOT. If it's less than 25%, it's mild. If the vena contracta is less than 3 millimeters or 0.3 centimeters, it's mild. If you look at your descending aorta and there's no early diastolic flow reversal, then it's mild. The pressure half time greater than 500 milliseconds. If the LV size is normal because not enough blood is going into the LV to dilate the LV, then it's also mild. Regurgitant volume less than 30 mLs. Regurgitant fraction less than 30%. And the EROA less than 0.1 centimeters squared. These are the things that make it mild AI. Okay? You have to know the table, just like how you have to know the table for aortic stenosis. You have to know the table for aortic insufficiency. So, that concludes the lecture for aortic insufficiency.